We're looking to gain elevation of the shoulders so that the client could reach her arm back overhead again. So here we're going to use some distraction to open up the joint, as well as some muscle energy, PNF, some hold relax to release and increase range of motion. Bring the client's arm up into her restriction. So say if this was as far as she could go in elevation, I could even let her arm rest on my shoulder. Stabilize and anchor down the scapular border, lateral border of the scapula. You have teres major coming in through here, latissimus dorsi going down to the back. Those are the primary muscles that are limiting overhead flexion. Get a nice purchase on the distal humerus, a little distraction while you stabilize the scap. So get some nice distraction here. Bring her to her barrier, and they'll let you know when to hit the barrier. So hold it there. Now I'm going to ask you to pull your elbow down toward your hip here. When I say go, very lightly. Ready? 1, 2, 3, go. Pull down. So I'm resisting shoulder extension, contracting the lats and teres major, and relax. For just 2 or 3 seconds, nice and light. Take up the slack into the new barrier, maintaining that distraction on the glenohumeral joint. So hold that stretch 15 to 30 seconds until you feel it release. Push down again toward your hip. Ready? Go. 1, 2, 3. Nice. And relax. Nice and easy. Good. And breathe and come into the next barrier. So you could usually get several degrees of range of motion in doing even 3 to 5 reps of this hold relax. So push up again. Good. Into my finger. Sometimes a little tapping, cueing for a patient, and relax. They forget which way to go. And stretch. Now, when you get up into the higher ranges of elevation, you need to monitor to check that the lumbar lordosis is not increasing, that they start having an anterior pelvic tilt, because the latissimus attaching into the lumbar dorsal fascia and into the shoulder, superior proximal shoulder, is also going to cause that tension to pull down into the back. So you might see that that hip is hiked up on one side, you might see it excess lumbar lordosis. So I like to make sure I have the hips and knees flexed, flatten out the back, or even tell the patient, feel my hand under your low back, feel my fingers poking you, squish my fingers right there. So as they contract their transversus, do a little bit of a posterior pelvic tilt and hold, that keeps their neutral pelvic position. So a nice way to increase overhead elevation for flexion.